Hello, everyone, and welcome to Chapter 25. The focus for this week's chapter is on the RNA viruses, and specifically, we're looking at the viral infections that target humans. We will talk about some viruses that are zoonotic, meaning that they have animal origins as a reservoir. However, due to some of the genetic modifications and changes, are able to infect humans, in often cases in a very significant way. Chapter 25 is a follow-up from last week's chapter, Chapter 24, on the DNA viruses, as we started to talk about things like varicella zoster, herpes virus, and many of the hepatitis viruses as the major content from last week's chapter. This week we'll be talking about a lot of different viruses. There's a much wider range here, from things like rubella and rubeola, which can cause things like the measles and mumps, to the gastrointestinal viruses. And also we'll talk about influenza, rabies, polio, and HIV this week are all going to be on the docket for our discussion. So let's pop in and start with a general overview of what the RNA viruses are. So RNA viruses are broken into 12 families, and remember, anytime we see this family, we know that the ending viridae is symbolic that we are talking about a family of viruses. So there are 12 different families in the RNA virus category, and the differences are based on whether they have an envelope, the structure of their capsid, and the nature of their RNA genome. Again, being single-stranded or, in one case, a double-stranded RNA genome. This is a really nice overview. This is something that I like to keep as I'm going through the chapter, just because it's going to break up our lecture today into the enveloped viruses, which can either be single-stranded or have this enzyme, which is known as reverse transcriptase. And reverse transcriptase is significant because this is an enzyme that allows us to take an RNA genome and convert it backwards into DNA. So most times the central dogma of genetics goes DNA to RNA to protein. Well, the retroviruses, which is the key group, have an enzyme known as reverse transcriptase, and this reverse transcriptase enzyme allows them to take their RNA code and convert it back into DNA. And we'll get into that in a little bit. We'll also talk about viruses that either have a segmented or a non-segmented genome. So you can see many of those examples down here of the ones we're going to get into today. We'll also talk about the non-enveloped RNA viruses, and a lot of these are some of the gastrointestinal viruses, the caliciviruses, such as Norwalk virus, and the reoviruses. Be careful, reovirus sounds a lot like retrovirus. The reoviruses are your diarrhea viruses, things like rotavirus, which is particularly impactful for young children. And again, your book does a nice job at organizing the virus based on the body system that it is going to attack. So it gives you the virus name, the diseases, and also the body system of target. So this is a really good tool to be able to go back to as you kind of construct your table overview of the different viruses in this chapter. So we are going to start today on the left side of the key, the dichotomous key over here, with the enveloped viruses. And we're going to get into first looking at the very left-hand side, which are our segmented viruses. And remember that the majority of RNA viruses are single-stranded. They're just like we saw DNA viruses, the majority are double-stranded, except for one particular group which has that single-stranded composition. So we're going to talk about the orthomyxoviruses, the Bunya viruses, and the arena viruses as we get into this particular section. So there are three distinct types of influenza, which is the primary disease caused by the orthomyxovirus family. And the three different types are coded with a letter: influenza A, influenza B, and influenza C. And type A is the one that is known to cause the most infections of all of the three different types that have been studied and identified. So you'll see down here, we have in this table, we have our three different types, A, B, and C. And then they also list, if you are familiar with any of the influenza outbreaks, they are identified with a subtype. And each subtype is given a number abbreviation. So H1N1 or H2N2. This H and this N describe two of the enzymes that are prevalent on the surface of the influenza virus: hemagglutinin and neuraminidase, both of which we'll talk about in a little bit, have key functions to allowing the virus to infect a host. So you can see kind of some of the major pandemics. Here's the Spanish flu of 1918, which is the one we often hear about. The swine flu outbreak, the Asian flu pandemic. Those are some of the big ones that we have seen over the years. Influenza infection. So let's get into and start talking about the biology of how the virus infects cells. So this is obviously a respiratory virus. It is multiplying and entering into the cells of the respiratory tract. The segmented virus, meaning that it's composed of segments of RNA, enter into the nucleus. The virus will then finish its assembly and bud off of the cell. So since this is an animal virus, it will go through this exocytosis, where it basically pinches off a section of this host cell membrane surrounding the core of the virus. So if we remember, the virus is going to enter through endocytosis, where it informs this kind of invagination of the host cell membrane, attaching by these hemagglutinin spikes. So the hemagglutinin spikes are going to allow the virus to help enter the cell. We mentioned earlier the neuraminidase spikes. The neuraminidase spikes are important because they are going to hydrolyze the mucus coating in your respiratory tract. The mucus coating is a material that is basically sloughed off to protect you from having any infectious agents being able to bind to those epithelial cells. However, the neuraminidase is able to allow the virus to hydrolyze and break through that mucus coating. So the virus then gets endocytosed into the cell, and once it's in, the viral cell itself is the virus itself is uncoated, and those materials are then brought into the host cell nucleus. So all of the viral DNA, or all of the viral RNA and the parts that make up the virus, will then be kind of manufactured to assemble the new virus and release those new viral particles out of the cell. So a lot of this is occurring within the confines of the nucleus. We've already mentioned the glycoproteins, hemagglutinin, which is allowing it to bind to the host cell, and the neuraminidase, which is hydrolyzing that mucous membrane of the respiratory tract. Both of these glycoproteins can undergo genetic changes, and that can alter the treatments as well as the vaccinations that are prevalent for the influenza. So that's why we often see every year that the virus vaccinations are often tweaked and modified, and you have to receive a new influenza vaccination each year because of those changes to the specific places of the virus, like hemagglutinin and neuraminidase. So we have two major types of genetic change that occur when we're talking about influenza. Antigenic drift is what we see for the yearly flu viruses. There is, every year as it passes through from host to host, there are slight mutations to the genetic message that are made. And this ultimately causes a slight composition change to the amino acids. So that's physicians and scientists are able to anticipate some of those changes each year, studying different types of viruses that are collected and studied from hosts, and are able to make modifications to the vaccination. Antigenic shift, on the other hand, is the much more severe one. And this is oftentimes where you get two different flu viruses, maybe one from a duck and one from a human, that happen to infect the same animal at the same time. And when this happens, so once you have these two different viruses impacting the same animal, there's a genetic exchange between those segmented viruses. And once this new virus emerges, kind of this hybrid of these two, it is now able to infect the human. So this zoonotic virus then infects the human. And our immune system really has not had any system to be able to target and destroy it. So the symptoms are often much more severe. So we mentioned earlier that there's 3 different types of influenza strains. Influenza A is the most virulent, and it usually infects birds. And then after 2003, we began to see it start to shift to infecting humans much more. Influenza B only undergoes antigenic drift, so slight changes to the genetic code, no antigenic shift. And influenza C only causes very minor respiratory disease. It's not really implicated in any of the global epidemics or pandemics that we have seen in the past. So influenza A is really the one that we think of on our yearly influenza outbreaks. It is incredibly contagious, as you know. It's a respiratory illness, and it's among one of the top 10 causes of death in the United States, most commonly among the very old and the very young. We mentioned that using that neuraminidase enzyme, it's able to bind to the ciliated cells of the respiratory tract and basically cause your respiratory cells to shed. And this causes massive inflammation. We also see symptoms such as fever, headache, myalgia, pharyngeal pain, which is a sore throat, shortness of breath, and coughing. And folks who have a weakened immune system are more predisposed to other types of secondary infections like bacterial infections, especially pneumonia. So that's really important to truly understand. So how do we diagnose it? Well, we can do immunofluorescence testing to look for antigens from a throat specimen. We can also do a testing of the serum, blood serum, to look for the antibody titer, the amount of antibodies produced for influenza. And there are a load of different treatments that are on the market today, including things like amantadine, rimantadine, zanamivir, and the one that we think of, oseltamivir, which is the common name is Tamiflu. That's the one that's often prescribed to you when you go to the pharmacist after contracting influenza. The flu virus has a very high rate of resistance to both the amantadine and the rimantadine. We know that the influenza vaccine is recommended annually each year, and the virus is actually grown within poultry eggs to be able to create the vaccination. And we know that there's really 2 different types of vaccinations. You can either have the intramuscular injection, or there is an attenuated vaccination. And attenuated basically means that you're receiving pretty much the intact virus, but it's been inactivated in some form. And that attenuated vaccination is often administered nasally. And most times you are administered 3 different strains in that vaccination. So now we're going to talk about the Bunya and the Arenaviridae, and basically do a little comparison between them. So both of these are transmitted zoonotically, so they're animal-borne, And we see oftentimes small epidemics that can be extremely dangerous as they arise. And these are really very intricate to work with in the lab. They have a biosafety level of 4, which is extremely high. So they are incredibly dangerous and highly contagious. The Bunya viruses are transmitted through insects and ticks, and it can cause a series of infections, things like Korean hemorrhagic fever, California encephalitis, Rift Valley fever, and also one that we know of is hantavirus, which is also known as the sin nombre hantavirus. And this causes a pulmonary syndrome that involves not only a high fever, but also a flooding of your lungs with fluid. So you get this massive edema and swelling, which ultimately relates to pulmonary failure. The instances of shock and death are greater than 30% in cases that are acquired. And we know that it's zoonotic, and it is its origin is from deer and harvest mice. So transmitted to humans via the animal waste, the fecal matter. The arenaviruses, on the other hand, include things like Lassa fever, Argentine and Bolivian hemorrhagic fevers, and we also have a lymphocytic choriomeningitis that are some of the conditions responsible from this virus. It has a rodent host, and it's transmitted again, just like the Bunya viruses, through aerosols as well as contact. So both being zoonotic infections. All right, so that wraps up our enveloped segmented single-stranded RNA viruses. We're now going to move into kind of the second column of our flow chart from earlier. Let me pop back to that just so you are able to kind of see what I am talking about. So we are going to pop into this second column here now, this non-segmented genome, and many of the viruses that we're going to spend the most time on today. So we're still under the envelope side, but we're talking about the non-segmented genomes now. So with that being said, we're going to start with the paramyxoviruses, and the paramyxoviruses include the parainfluenza and mump viral families, the measles virus, and RSV, or respiratory syncytial virus, which is caused by a pneumovirus. We'll get into the rhabdoviridae, which are the rabies viruses, the coronaviridae, or coronaviruses, the togaviridae, and this is where we find rubella, the flaviviridae, or hepatitis C, and we started to talk about hepatitis viruses in chapter 24. And we'll talk about the filoviridae, or filoviruses, and the big one here is the Ebola virus. So the paramyxoviruses are really broken into a few different groups. We've mentioned already the paramyxoviruses, things like parainfluenza and mumps, the morbilliviruses, or the measles, and we'll spend a little time here on the pneumoviruses, or RSV. And RSV is a transmission through the respiratory route. The envelope of the virus possesses what are called F spikes that really initiate the fusion of cells. And as these cells start to fuse together, they form these giant multinucleated cells, which we call syncytium. And we've talked about this in prior chapters. So basically, you just create this massive merging of cells in a pneumovirus infection. So again, you've really got 3 different cells that are kind of coming together, and the cells are fusing together to form this giant one multinucleated cell. Parainfluenza is widespread like the flu, but a little more benign, meaning the symptoms are not as severe. Still transmitted by the respiratory route, but seen mostly in children, such as infants, and the infection can be life-threatening in very young children. Other cases see things like minor colds, bronchitis, which is an inflammation of the bronchi, the tubes that lead into the lungs, which thus can lead to an inflammation of the lungs known as bronchopneumonia, and croup, which is kind of this coughing syndrome. There is no specific treatments available for this, but there are supportive therapies to help with the breathing and the inflammation to make the symptoms a little less severe. We talk a lot about the mumps, and the mumps cause a condition known as parotitis. And parotitis is this swelling that occurs in the parotid salivary glands. So you get this kind of swelling in the cheek and upper neck region that is often incredibly painful. Humans are the only reservoir of the mumps. About 40% of infections are subclinical, and long-term immunity is generated after infection. Relatively low incidence in the population, about 300 cases in the United States each year, with symptoms lasting about 2 to 3 weeks after incubation, including things like fever, muscle pain, and the swelling, as we mentioned, in the parotid salivary glands in either one or both cheeks. There are some complications to the other organs. About 20 to 30% of males will see things like epididymis, where the testes become infected. Sterility is incredibly rare, but there are possibilities of it. And the vaccine is the MMR vaccine, which is an attenuated vaccination. And since it's attenuated, we mentioned earlier that it's really like an inactivated form of the virus. So the attenuated vaccines like MMR are not going to be given to immunocompromised or even folks who are pregnant at the time, just because of some of the complications that can occur. So oftentimes, the way that we help to protect the folks who are immunocompromised in the population is through herd immunity, by making sure that if you are healthy, you are accepting vaccinations to limit the incidence and prevalence of infection in the population. So we'll talk about the measles now. The causative agent of the measles actually damages the respiratory mucous membranes. And the humans are the sole reservoir of the morbillivirus, which is also sometimes called red measles or rubeola. Measles are incredibly dangerous for females who are pregnant. It can often lead to things like miscarriages, low-weight births, and even premature births. It is very contagious, transmitted respiratorily through aerosols. And again, like we saw with back here with the mumps, even less prevalent in the population, only about 100 cases per year in the United States, all because of vaccinations and the generation of herd immunity. So we mentioned initial symptoms can include things like sore throat, dry cough, headache, inflammation of the conjunctiva, lymphadenitis, and fever. The key clinical characteristic sign that we get with measles or rubeola are these things called Koplik spots, which are oral lesions that form in the surface of the mouth. There is also a maculopapular rash that forms on the head and then eventually progresses to the trunk and the extremities, and we call this an exanthem. So this is also another key clinical sign that would suggest that somebody is infected with the measles. So you can see these kind of white spots. Sometimes they have a blue center to them in the oral cavity. These are the Koplik spots, which are those oral lesions that form. There are occasional causes of pneumonia that are seen with the measles. Also, very rare complications from things like encephalitis. And there is also another very serious complication, which is known as SSE, or subacute sclerosing panencephalitis, which is this progressive brain degeneration that occurs. Only about a 1 in a million cases see this, so it is extremely rare, but it is extremely fatal. Leads to a coma and death, usually in several months or years. Again, also protection is received through administration of the attenuated MMR vaccine. Healthy people get it, generate that herd immunity to protect folks in the population, elderly, immunocompromised, females who are pregnant that are not able to receive the vaccination at that time. So we have two forms of measles. We have measles, which is the rubeola, and we also have something known as German measles, which is separate. Synonym for that one is rubella, or 3-day measles. You can see that we've got the morbillivirus as well as the toga virus, or togaviridae, both impacting children. The German measles does have the ability to cause congenital defects, birth defects, also stillbirths are seen as well. Key difference in a diagnosis stance: measles have to have the Koplik spots. German measles, the Koplik spots in the oral cavity are absent. We do see the subacute sclerosing panencephalitis as a complication. The congenital defects are seen when transmitted to the baby in the uterus. RSV, or respiratory syncytial virus, is also sometimes called pneumovirus. It infects the upper respiratory tract and produces those giant multinucleated cells that we saw earlier. Prevalent cause of respiratory conditions in very young children, 6 months or younger. And basically what we see is the epithelia of the nose and the eye are the portals of entry, replicating in the nasal pharynx and causing conditions such as fever, rhinitis, which is a runny nose, pharyngitis or sore throat, otitis, which is the inflammation and swelling in the middle ear, and that coughing condition known as croup, kind of dry, barking cough. Treatment is a series of conditions of monoclonal antibodies and immunoglobulins. Also ribavirin, which is a actually inhaled antiviral drug that is administered as well. Okay, we are going to move into the rhabdoviridae, which results in the rabies virus. And the rabies virus has a very unique capsid structure, forming almost this kind of lipstick or bullet-shaped viral particle to it. It is a zoonotic disease acquired from animals and has a very slow spread through the body. It is spread either through bites, scratches, and also sometimes through inhalation of droplets, being the key things. We often hear of it significantly with the bites. The symptoms of rabies usually occur, as we saw here, it happens very slowly, about 1 to 2 months after the entry of the virus to the body. And this is either going to be slower or faster spread based on a couple of conditions. So it's going to determine the length of the journey for the virus from the site of the bite to the brain. So if you're bit on the ankle by an animal, the journey for the virus is going to be much longer until it reaches the brain. If you're bit on the upper arm, for instance, the spread is going to occur much quicker. Also, on top of the length of the journey, happens to be the amount of virus that enters into the wound. So that is also going to shape how long of an incubation period the virus has. One of the key clinical signs after a bite is a tingling or twitching at the site of the bite. So the transmission of this virus is really through an infected saliva. The infection cycle completes when the virus replicates or starts to replicate in the salivary glands. And there are a few key clinical phases as the virus progresses. The first one is known as the prodromal phase, and this is where you get some of these more common symptoms: fever, nausea, vomiting, headache, fatigue. And we mentioned the tingling or twitching at the bite site. This is followed by the furious phase, which includes things like being agitated, disoriented, seizures, twitching, and hydrophobia, which occurs with these kind of painful spasms of the throat at the sight of water. Then there's what they refer to as the dumb phase. And this is where there's disorientation, there's paralysis, and this ultimately results in a coma and then eventually death. Clinical sign-wise, one of the key things that we see is the presence of these inclusions in the cells known as Negri bodies. So that's really important in terms of the autopsy. When they start to microscopically examine specimens and tissues, they look for the presence of these intracellular inclusions known as Negri bodies. So how do we treat rabies? Well, there is a post-exposure immunization that consists of immunoglobulin that is administered, usually in 6 doses with 2 different boosters. It's an inactivated vaccine. And we can control it, obviously, through vaccinations of domestic animals, avoiding strays, and making sure that we are practicing proper animal control. We now move into the coronavirus family. The coronaviruses are relatively large viruses, and they have these distinctively spaced spikes on their envelopes. There are 5 basic types that have been characterized, and most cause things like the common cold, viral pneumonia, enteric infections, and also what we know as SARS, which is referred to as severe acute respiratory syndrome. I imagine in the next edition of our textbook, whenever that happens to be, we will get much deeper into the current coronavirus, the SARS-2 pandemic that is impacting the United States population. And at the time of this recording, we are currently at 546,000 deaths from the coronavirus since the start of the global pandemic in March of 2020. So let's talk a little bit more about SARS. It is a relatively new emerging disease, was first documented in Asia in 2002. It is transmitted through either droplet or direct contact and includes things like fever, body aches, and malaise. Severe cases result in respiratory distress and ultimately death. So a lot of the treatment is supportive to support breathing processes and things like that. We mentioned the rubella a little while ago, which is caused by the rubavirus, which is a togavirus. So this is a single-stranded, again, RNA with a very loose envelope. Causes a condition known as the German measles, and it's transmitted through contact with respiratory secretions. The vaccine is very important for this particular, as we mentioned earlier, for this particular type of measles, to help achieve herd immunity. And at one point, they thought that boys and girls were protected very differently from the vaccine. That is not the case. It appears that boys and girls are equally protected, and that everybody should receive the vaccination to help build that herd immunity in the population. So it's spread through this respiratory secretions. Most cases are asymptomatic. However, we mentioned earlier that In some cases, it's able to cause congenital defects such as birth defects and stillbirths. Also vaccinated through that attenuated MMR vaccine, that measles, mumps, and rubella. So we've got the postnatal rubella, and we've got the congenital rubella, which is most likely to occur during the first trimester and induce, as we mentioned, stillbirths, miscarriages, and other abnormalities in recently born infants. Things like cardiac abnormalities, ocular lesions, and mental and physical retardation. Hepatitis C is caused by a flavivirus, the flaviviridae, and we started to get into and talk about the hepatitis viruses in chapter 24. Hep B and Hep C are incredibly similar to each other with regards to the routes of transmission and the portal of entry. So very similar, HCB and HCV. Or HBV, excuse me, and HCV. Sorry, I got that one a little backwards. They are acquired through things like blood contact, transfusions, needle sharing. 75 to 85% of infections will remain indefinitely. And there are some possible severe symptoms such as liver damage. We call this cirrhosis of the liver. More common to have chronic liver disease. And cancer may also result from HCV infection. So we often see that things like hepatitis A and hepatitis E are similar together. They're both transmitted via the fecal-oral route. HBV and HCV are similar in the fact that they both have very similar routes of transmission. The hepatitis C is actually one of the most common chronic bloodborne infections that we know of today. So that's really important to understand. Treatments usually occur with things like interferon and ribavirin, which will help to lessen the liver damage. And there is no cure for hepatitis C, and there's no vaccine as well. Hepatitis B is the one that we commonly think of with the vaccination. All right, we are going to move into the Arboviruses, the Arboviridae. And the reason these are called the Arboviruses is they all require spread via a arthropod vector, some type of an insect, mosquito, tick, fly, gnat. 400 different viruses that comprise this family. We have things like the toga viruses, the flaviviruses, some of the Bunya viruses, and the reoviruses all fall into this particular group. Most of these illnesses cause mild fevers. Some can cause encephalitis, and there are a handful that are able to cause hemorrhagic fevers. We'll talk about yellow fever today, which is one of the most common hemorrhagic fevers that we know of. Again, all of these are enveloped, single-stranded RNA viruses. So the vectors tend to arise depending on the tropic area, the climate zone that they originate from. So the arboviruses are part, oftentimes, of the vector's life cycle. And infections thus will show a peak when the arthropod is actively feeding, growing, and reproducing. So if you've got mosquitoes out in warmer climates and they're biting people and they're starting to congregate and breed, you will see higher levels of infection. Humans can serve as kind of the accidental host, or they can help to maintain the reservoir, depending on the incidence in the population. So controlling the vector controls the disease. If you reduce the populations of mosquitoes and ticks, that is going to ultimately decrease the numbers of infections. So here's kind of the worldwide distribution of arboviruses that we see today. And you'll notice that most of them are in the warmer climates right around this equator region. So that helps to sustain those vector populations. So acute arbovirus infections may result in undifferentiated mild fevers with rashes. And when we talk about acute, that often means that there's a rapid onset and it goes away relatively quick. When we talk about chronic, obviously one of the most popular chronic infections that we know of is hepatitis. That means that you have consistent infections for indefinite amounts of time. So prominent symptoms, again, with the arboviruses include things like the fever, headache, myalgia, joint stiffness, and rash. However, there are opportunities where encephalitis occurs, and this is an inflammation of the brain, the meninges, and the spinal cord. And this ultimately results in things like convulsions, paralysis, tremors, and ultimately coma and brain damage can result. So let's talk about some of the arbovirus infections prevalent in the United States. We have West Nile virus, which is transferred via mosquitoes from bird blood. 80% of folks show no symptoms, and less than 1% will develop a neurological illness such as encephalitis. There is Colorado tick fever, which is the most common tick-borne viral fever in the U.S., found in the Rocky Mountain regions. Tripoli, which is one we see a lot of, is prevalent on the East Coast in Canada. La Crosse encephalitis is found in the Midwest, Appalachian region. St. Louis encephalitis is a silent infection common across all of America. The chikungunya virus is found in the Caribbean. Most patients are symptomatic. They have the fever, muscle aches, the joint stiffness, the nausea. Mortality is extremely rare. The Zika virus is very similar to the chikungunya virus, or what we will talk about in a little bit, the dengue virus. And there are birth defects that can occur if the mother is infected during pregnancy. So we're going to talk about our hemorrhagic fevers now. The first one we'll get into is yellow fever, which has been eliminated in the United States and has really two patterns of transmission. There's an urban cycle, which is between humans and mosquitoes, specifically the Aedes mosquito. And there's the sylvan cycle, which is significant between forest monkeys and mosquitoes, and that is prevalent in South America. And we oftentimes see our fever, headache, muscle pain, and obviously hemorrhaging. Anytime we get hemorrhaging, we're also going to get organ damage, like liver and kidney damage, and also jaundice or yellowing of the skin. That's why it's referred to as yellow fever. Dengue fever, on the other hand, is able to disrupt your capillaries and cause blood clots. It is responsible for what's known as breakbone fever and results in extreme muscle and joint pain, and it is extremely fatal. All right, we are now going to get into HIV. Another very important member of the enveloped single-stranded RNA family. Most cases of HIV today are in sub-Saharan Africa. And we still see today that the majority of these cases are acquired through heterosexual intercourse. It can cause acquired immunodeficiency syndrome, or AIDS, and it first emerged in the early 1980s. If you have not had a chance to see the movie And the Band Played On, it was created by Matthew Modine, was released in the early 1990s. I definitely recommend you to check it out. It's basically a movie that detailed the study and the journey to arrive at a detailed diagnosis of HIV. It can cause severe pneumonias caused by things like pneumocystis. It also is able to cause a very rare vascular cancer referred to as Kaposi's sarcoma, and it's often seen by the presence of these lesions on the surface of the feet and legs. There is a sudden weight loss, swelling of the lymph nodes, and just an overall loss of immune function. The reason for that loss of immune function comes from the damage to your macrophages and your helper T cells are the two big cells that are destroyed by HIV. We mentioned earlier that HIV is a retrovirus, meaning that it possesses this enzyme called reverse transcriptase. And reverse transcriptase can take your RNA message and convert it back into a DNA message. So that is incredibly important to understand. Why is that important to understand? Well, this is what leads to resistance in the HIV virus. So oftentimes you will hear that the treatment for HIV is what they call a cocktail, meaning that you are often prescribed several different medications, all with different targets. And the reason for that is let's walk through this. So we mentioned now we have this reverse transcriptase enzyme. And the reverse transcriptase enzyme uses an enzyme called a polymerase. And polymerase's job is to basically lay down all of the new nucleotides to make copies of the genetic material. Well, polymerase is incredibly sloppy. It has a very high rate of error to it. So as the reverse transcriptase is making the DNA version, and it's causing this very sloppy, high rate of error to occur, this leads to a very high rate of mutation for the virus's genome. So anytime you get a change in the bases, which can ultimately change your genetic code, this can lead to an increased chance for drug resistance. So by utilizing several different targets in that cocktail, we are trying to protect and make sure that we are impacting the virus in any way possible. The virus does integrate to the host cell chromosome. And anytime this integration into the host cell chromosome occurs, one of the things that happens is it might result in the loss of the control of your cell cycle. And if your cell cycle shuts down, so basically your cell cycle consists of a series of checkpoints that regulate how often your cells multiply and divide. Well, if we lose those control checkpoints, your cell cycle spirals out of control, and you get this massive production and proliferation of cells. This is what we know as cancer. So HIV is also able to, as we mentioned earlier, cause cancers such as Kaposi's sarcoma from the loss of this cell cycle control as the virus integrates into the host cell chromosome. We mentioned earlier that it is going to target, and anytime that we want to target treatment, we can go after a couple different things. We want to target these GP120 receptors that are on the outside of the virus. We also want to target the connections to the CD4 and the T helper cells. Those are targets to help keep the virus from entering into the cells. So preventing this GP120 from targeting and binding is very important as well. There are two different forms of HIV. There's HIV-1 and HIV-2. We also have what's known as, and we'll get into in a little bit, HTLV, and we'll get into talking about that. Sounds a little similar to HIV, but they're actually two separate things. HIV-1 and HIV-2 are T-cell lymphotrophic viruses. They can cause leukemias and lymphomas. And HIV is really responsible for attaching to CD4 proteins. And this is going to impact the macrophages and the helper T cells. So we talk about that GP120 receptor. We already mentioned that the retrovirus allows the genes to integrate into the host chromosome as well. So how does HIV cause infection? We've already looked at some of the routes: blood exposure through needles, sexual intercourse, and that can be anal sexual intercourse as well, semen, vaginal fluid exposure, and obviously, breaks in the cells of the skin or membranes as the portal of entry. Babies can be infected as well, either before or during birth, as well as from breastfeeding. And HIV is really not a hardy virus. It doesn't do very well outside of the human body. So it requires that host cell for all of its metabolic functions. It was first deemed a nationally notifiable virus by the CDC in 1984, and it's now the 6th most common cause of death for folks between the ages of 25 to 44, with men accounting for about 75% of those infections. We've mentioned already that the significant factor is spread through heterosexual sex. Also, IV drug users can be impacted as well. In 2009, the number of infected individuals worldwide was about 35 million, with 1.2 million in the US. We mentioned that most of the cases are found in sub-Saharan Africa. So how does the virus cause its disease? What are the virulence factors that allow it to get in there and do its damage? Well, we have the HIV virus entering through the mucous membranes or the skin, and it travels to your dendrite phagocytes beneath the epithelium, where it multiplies, and then the new virions are shed. The virus is taken up by your macrophages in the skin, lymph nodes, and bone marrow. And the virus will eventually attach to your CD4 proteins and fuse with the cell membrane. Remember, we saw that CD4 and GP120 receptors binding together. Once inside the cell, the reverse transcriptase enzyme is going to take the RNA genome and make a DNA copy of it. That viral DNA then gets integrated into your host chromosome. And remember, this is what we saw generated a lot of those cancers due to the damage of the cell cycle checkpoints. And it can either produce a lytic infection, where the host cells are lysed, releasing the new viruses, or it can integrate and remain latent for some period of time. And this is why the incubation period of HIV is often unpredictable. So let's talk about the stages of HIV infection and ultimately the production of AIDS. So the pathology of the virus is tied to two factors: the level of the viruses and also the level of T cells that are in your body currently. So the primary effects of HIV infection are first times destroying the white blood cells, leukopenia, formation of these giant T cells, multinucleated T cells, where the virus is able to spread from cell to cell. And infected macrophages are going to have the possibility of releasing the virus in the central nervous system. Secondary effects are ultimately the damage of those CD4 cells, which can result in a whole slew of opportunistic infections and cancers that leads to what we call acquired immune deficiency syndrome. Basically, there is now a deficiency of your immune system that allows a panel of syndromes to arise. So again, if you take a look at, we initially, upon infection, you have this massive jump of the virus, but then it's able to go latent for some period of time and then could reemerge again at a later point. So symptoms, as we mentioned, are related to the amount of virus in the blood as well as your T cell level. Your initial infection is going to kind of resemble mono, this kind of weakness, always appearing tired. There's then some type of an asymptomatic phase. It can range between 2 and 15 years, followed by AIDS, which is where the immune system has now been destroyed. Your T4 cell levels have fallen, and you now get a series of opportunistic infections or cancers that can arise. So how do we diagnose HIV? Well, testing is based on looking for antibodies in the blood specific to the virus. Initial screenings can include things like the ELISA assay, antibody tests. Follow-ups with the Western blot analysis will serve as kind of your confirmatory tests from the presumptive ELISA testing. And it is possible to have false negatives. So folks who often receive one test will receive a second one several months later to confirm if there is a positive. Diagnosis occurs with the following criteria. The person is obviously positive for the virus, and they have one of the following. Either their CD4 count is below 200 cells per microliter in their blood. Your CD4 cells account for less than 14% of all of your lymphocytes. And you experience one or more of a list of illnesses that the CDC has deemed chronic for AIDS patients. And I'm not going to walk you through this, and you won't necessarily have to know this for a test. I'm not going to ask you this, but this is some of the different conditions defined as prevalent for AIDS and the different body regions. So how do we prevent and treat infection and AIDS? So there is no vaccine available. Obviously, it's remaining monogamous with sexual relationships, use of oral contraceptives, and universal precautions, gloves and gowns, when handling bodily fluids. There is also no cure. There are therapies that will slow down the progress of the disease and diminish the symptoms, such as the inhibition of viral enzymes. So we're going to talk about this now. We can either inhibit the reverse transcriptase. There's protease and integrase inhibitors. Protease inhibitors, what they do is they actually interfere with the HIV enzyme that's responsible for the final viral assembly and maturation. So they stop the virus from basically being put together. The integrase inhibitors interfere with the virus inserting itself into the host DNA. So the virus is not able to integrate its DNA code into the host cell chromosome. And then obviously the reverse transcriptase inhibitor stops the reverse transcriptase enzyme from making a DNA copy of its RNA genome. So these are often given as a cocktail where all of these are given as one treatment to really target all of these different pieces. All right, let's talk now about the HTLV or human T cell lymphotrophic viruses, such as HTLV1, which is responsible for an adult T cell leukemia. It's a malignant disease of the white blood cells in the bone marrow. And all of these leukemias are acquired. There is no inherited leukemias. Some are acute, some are chronic, and they first manifest with basically as bruising or bleeding, paleness and fatigue. And there's a series of underlying pathologies such as anemia, which is a lack of iron in the blood, platelet deficiency, and other immune dysfunctions that are brought about by this disrupted lymphocyte ratio. So we mentioned we have HTLV1, which is that human T-cell lymphotrophic virus, causes the adult T-cell leukemia. And there's also HTLV2, which is a close relative. There's really no distinct disease noted at this time for HTLV2. So HTLV1 is the one that we commonly refer to. The next part, so we're going to kind of start to shift a little bit now. And if we're looking at I want to scroll all the way back up top. We go back to our original image. We've now covered the enveloped side of our dichotomous key here, looking specifically at the single-stranded and segmented, non-segmented in our retroviruses. We're now going to move over here to the very right and start to talk first about our single-stranded and non-enveloped RNA viruses. So I'm going to scroll down to that one. All right. So the first one we're going to talk about are what we call the picornaviruses. And these are named because they have a very small size, and their RNA core is incredibly small as well. And there are two important genera here. There's the enterovirus and the rhinovirus. Rhinovirus causes the common cold. Enterovirus is responsible for things like poliovirus. And then we also have something known as cardiovirus, which infects the heart and the brain. So this is again, another table just organized to help you see some of the different picornaviruses that we're going to get into now and the diseases that they cause. We're going to start with the first one, which happens to be poliovirus and causes a condition known as poliomyelitis. The poliovirus impacts the spinal cord and can actually cause paralysis. So when we talk about polio, we're actually talking about destruction to the motor nerve cells. And it is acquired through an oral entry, through fecal contaminated water, usually. And these picornaviruses fall into this enterovirus group. So the poliovirus is a naked capsid, meaning it does not have an envelope. But it's also resistant to acid, bile, and detergents, which means it can survive passage through the stomach. As we mentioned, this is orally ingested through fecally contaminated water. Vaccinations have helped to reduce the number of cases to very slim. We really don't see much of it in the population anymore. The polioviruses adhere to your receptors in your mucosal cells in the oral region and in the intestine, and they can multiply and shed in the throat and feces, with some of them leaking into the blood. Most of the infections with polio are very short-term and mild. They can even be asymptomatic and include things like headache, sore throat, fever, or nausea. However, there are some that are able to be more severe, but the most are very asymptomatic. If the viremia persists, meaning it starts to circulate in the blood, that's when it gets to the brain and the spinal cord and can destroy the nervous tissue or can cause things like muscle pain and spasms, meningeal inflammation, and hypersensitivity. That invasion to the motor neurons causes a condition known as flaccid paralysis. And later polio syndromes, which have muscular deterioration, occur in about a quarter to half of all patients that were infected with polio during their childhood. So the paralytic disease includes the muscles of the legs, the abdomen, the back, your intercostal muscles, the diaphragm, which controls breathing, your pectoral girdle, and your bladder. So, and oftentimes there is also a very rare condition known as bulbar poliomyelitis, which can often require a mechanical respirator to keep you alive. Severe deformities of the trunk, we mentioned the flaccid paralysis as well, are all common from the impacts of polio. So how do we treat and prevent polio? Well, treatment, again, is largely supportive for the pain, for the breathing. We mentioned the artificial ventilation in some cases. There is a vaccination. The inactivated polio vaccine is also called the Salk vaccine, and this was named after Jonas Salk, who developed the vaccination in 1954. There's also an oral vaccine known as the Sabin vaccine, which is an attenuated virus, and it's no longer recommended for administration in the United States. And we are working on, through the vaccination campaign, basically eradicating this worldwide. We also have the non-polio enteroviruses, such as the Coxsackie viruses and the echoviruses. So they are similar in their epidemiology, but less virulent than polio. They're responsible for respiratory infections, conjunctivitis, and even something called hand, foot, and mouth disease. There's very rare cases of these viruses causing things like meningitis and paralysis and impacting the brain and spinal cord. The initial phase of infection is usually intestinal. The virus is then going to enter the lymph and blood and move to the other organs of the body. Important complications, again, you can have common cold syndromes in children, pleurodenia. You can even have paralysis, we mentioned, meningitis, eruptive skin rashes, hand, foot, and mouth disease, and even in some cases, an acute hemorrhagic conjunctivitis can form as well. Hepatitis A, we mentioned earlier, is very similar to hepatitis E and is very different from hepatitis B and C in the fact that it is fecally orally transmitted, and most folks are asymptomatic reservoirs. So they don't even know that they have the disease. There's no clinical disease. The virus multiplies in the small intestine and can enter the blood and be carried to the liver. We mentioned that most cases are subclinical or vague. Sometimes there is flu-like symptoms. Jaundice usually does not occur like we see with hepatitis B and C. There's no specific treatment once the symptoms begin. However, there is a vaccination. There is an inactivated and attenuated viral vaccine. There's also immune serum globulins for those who are entering into areas where the prevalence of hepatitis A is incredibly high. The inactivated vaccine is known as Havrix. And also, it's important, we mentioned earlier that as this virus kind of enters into the liver, you can get kind of a discomfort in the region of your body near the liver. And in some cases, they also see that it causes your urine to darken in color. But this immune serum globulin that is administered can help to decrease the severity of the viral infection. We also have the human rhinovirus, which is associated with the common cold. There are molecular surface markers that are unique, and this makes developing a vaccine very difficult to do, since there are often several strains that are circulating across the population at any one time. These rhinoviruses grow incredibly well in the cool regions of your respiratory tract. So this is why they prefer those particular areas. And they're acquired from contaminated hands through direct contact or contact with surfaces like fomites. They are sensitive to acidic environments, requiring like an optimum temperature of about 33 degrees Celsius. We see the symptoms of the cold that you're pretty familiar with: headache, chills, fatigue, sore throat, cough. And hand washing and care are the most common pieces to help prevent spread of the rhinovirus. Lastly, we'll talk about the non-enveloped, non-segmented, single-stranded RNA viruses. This particular one here is known as the calicivirus and is also referred to as the Norwalk agent, is the best known of the family. It's believed to cause about 1/3 of all viral gastroenteritis. Fecal-oral transmission. It does not have a prevalence for age, and often results in nausea, vomiting, cramps, and diarrhea. Rapid and complete recovery usually occurs with this particular infection. We have our rheoviruses. Rheoviruses cause cold-like upper respiratory infections. The ones that we think about are oftentimes the rotaviruses. And the rotaviruses are significant because it impacts infants and children. Fecal-oral transmission. Death usually occurs by dehydration from the diarrhea. You shed massive amounts of water and electrolytes. Worldwide, rotavirus is the primary viral cause of morbidity and mortality from diarrhea. That's huge. Worldwide, it's the primary cause. We also talk a lot about the rheovirus as well, which we mentioned has that cold-like upper respiratory infection. And I do want to also say that with the rotavirus, this is infecting the epithelial cells of the small intestine. So that's really the target cell that's being impacted by the rotavirus. We also have something called norovirus, which you probably have heard of. It's associated a lot with cruise ships. Norovirus impacts people of all ages. And it's a really relatively short-lived diarrhea that occurs and lasts about 3 days in length. So I wanted to mention that as well, because we hear rotavirus, but norovirus is similar in its impact as well. We're going to shift gears a little bit now and get in and start talking about the prions, or the infectious proteins. These often cause conditions known as spongiform encephalopathies, meaning that they impact the brain and the spinal cord. And the spongiform means that they actually punch holes in the tissue, causing this spongy hole-like appearance to form. Prions are made of only protein. Prion actually stands for proteinaceous infectious particles. They are one of the most resistant forms of microbial life that we know of. They're highly resistant to chemicals, radiation, and heat. And they have absolutely no genetic material. They're the only microbial form that we will discuss that have no DNA or RNA. They can cause spongiform encephalopathies in humans as well as animals. We usually talk about Creutzfeldt-Jakob disease, or CJD, in humans. Animals, we talk about things like mad cow disease, scrapie. There used to be a condition known as Kuru. That was a human disease, and that was acquired through ancient tribal populations that used to enact the process of cannibalism. Kuru was acquired from eating contaminated meat from individuals that had contracted the spongiform encephalopathy. Again, we mentioned their protein, no nucleic acid. Their resistance is incredibly high. They can even withstand autoclaving. They are not integrating into nucleic acid because they don't have any. And there's no inflammatory reaction or damage to the cells of the host. What they do in terms of Creutzfeldt-Jakob disease is they alter the structure of a protein found in your brain known as the PRP protein. The abnormal PRP form converts your normal PRP into the abnormal form. So they actually call this a transformation. This is not an infection. the prion actually causes your normal prion proteins in your brain to be converted to an abnormal form. And this abnormal form actually has the same amino acid structure. It just causes the change to the form itself. This abnormal form causes cell death, that spongy appearance, and loss of brain function. And transmission is possible through either direct or indirect contact with the brain tissue or cerebral spinal fluid. So again, you'll notice here is your kind of normal brain tissue, and then we have these spongy holes that have been punched by infection with the abnormal prion protein. The variant form of Creutzfeldt-Jakob became apparent in the late 1990s after meat was consumed from cattle that were afflicted with the bovine spongiform encephalopathy. This was the great mad cow disease outbreak of the late 1990s. It actually traveled over here to the United States and was prevalent for people that had ingested ground beef that was localized to the United Kingdom. We actually stopped the export of all meat products for several years. And the reason this kind of sprung up is they were taking the carcasses of the dead animals, they were grinding them up, and they were using it to as part of the feed for the cows that were living. Extremely difficult to diagnose. There is absolutely no cure. It is 100% fatal. Death is usually very swift, and it requires a careful biopsy of the brain and nervous tissue to avoid any contact with contaminated tissue during this time. So oftentimes, all of the gowns that are used in the autopsy are incinerated once they're done with. You'll also notice that the physicians wear metal chain gloves over their fingers to ensure that if they were to accidentally cut themselves with the scalpel, that it would not be able to cut through the glove. So they wear kind of a chain material over the glove to prevent that. There is no treatment available, and death is inevitable. All right, that wraps up the end of chapter 25. I know this is a big chapter with a lot of information in it, so take it slow, watch the lecture, print out your slides, be sure to take some notes as you're going through. If you have any questions this week as you're watching the slideshow, please feel free to pop into office hours. Take care, everybody.